we're going to be doing this a little bit differently today. I'll be fielding questions from out here in the audience. First of all, do we have any questions from the live audience at this point? Okay.
Hi. Thank you for this articulate presentation. One of the questions I have is what you were talking about with the gray area between, right above Medicaid, the new Medicaid eligibility. So if you make above minimum wage and entering, so either if you're going up and entering the private insurance exchanges, or if somebody is employed with benefits and then loses their job. Can you talk about what that would look like and how to get people into care that way?
One of the things that I know the Task Force on Continuity of Care here in Maryland and policies nationally are looking at is if you are engaged in treatment in particular. So we don't want to disrupt treatment. So let's use the example of someone who's receiving chemotherapy. If you've been approved for chemotherapy and then you lose your job, for instance, and then you're coming into the Medicaid system, how is it that your doctor or your treatment isn't, what's your prior approval? Does the new person, the new plan have to accept that prior approval, particularly going from Medicaid into the exchanges in particular? So thinking about what those agreements look like. Who's your doctor? Do you have to change doctors? Do you have to get all of your authorizations for your medications or your treatments done over again? Is there a disruption in whether you can refill your meds? These are questions, and I think right now we have a lot of questions about what this looks like. Until it actually gets implemented, we won't know what that looks like, and I imagine it'll be all over the board. Some people will be making a very seamless transition, and then for various reasons, other people will have trouble. I think we're really trying to put in place a system that minimizes that. There will be navigators and assistants, and I think a lot of people who will try to help with this. But ultimately, a lot of that is aimed at people who are very confident in using that kind of assistance, have a high level of health literacy. And so my concern is for particularly vulnerable populations. They're going to be relying on providers like Healthcare for the Homeless and other groups to really help them navigate that. So that may be both an answer and more questions back to you. But I think that this is an area that a lot of people are focused on and how that's going to work. And this is obviously both technically difficult in the computer systems and IT systems that are being implemented to try to navigate this, as well as just the warm handoffs between providers. And I'll turn to Kevin if there's anything he wanted to add to that.
That's good.
Okay, here's a question from online. Since the tragedy at Newtown, much attention has been focused on gun-related violence. How is the homeless population affected by gun violence?
That's a great question. And after the Newtown incident, I remembered a conversation that Barbara and I had on a policy committee call of the National Healthcare for the Homeless Council, when one of our members was suggesting that Healthcare for the Homeless develop a policy on gun safety and gun violence. And certainly in some communities like Baltimore, vulnerable people certainly are exposed to high levels of gun-related violence and death. But at the time on that call, we essentially said, important issue, but it's not really directly related to homelessness in a causal way, so not necessarily something we should take a position on. The day of that incident, I remember kind of remembering instantly that conversation and being vexed by it. And since then, exploring what is the relationship between homelessness and gun violence. And though I don't think there's a causal one necessarily, they're definitely related in that both are symptoms of failed public policies. Both are allowed to exist in the United States at higher rates than in any other industrialized nation because our policies related to guns and gun safety, and our policies related to housing, healthcare, and incomes and a sufficient safety net are fundamentally different in the United States than they are in other industrialized nations. So I think there's an interesting relationship between those two factors and something worth exploring further.
Hi. I wondered if you could talk to us about the initiative that the mayor is for the 75 homeless off of the street and how this relates to your concept about housing before treatment.
Yeah, it's fantastic. The 75 Journeys Home.
Yes.
Is the name. It takes place during what's called Registry Week. All of this is part of the National 100,000 Homes campaign, which is a national effort to house 100,000 of the most vulnerable people in the United States using a supportive housing or housing first kind of model. And so Baltimore is participating in this and is doing its census concurrently with this Registry Week, where service providers and volunteers will fan out across the city and administer what's called a vulnerability index. And this index is similar to the one that we've used now for many years to try to identify those that are most vulnerable and frankly most likely to die on the streets, and then house them. There's work already happening in Baltimore City to house vulnerable people. We just got word recently that 18 individuals, vulnerable people, this month will be getting keys to their own places. And that's just people affiliated with Healthcare for the Homeless. There's more throughout the city. All of this happens, though, when limited housing vouchers are made available. These are extremely, extremely limited. When affordable housing is not available, this kind of work can't happen. So I think the 75 Journeys Home campaign here is a wonderful expression of the housing first model being so effective. It is incredibly small relative to the broader scope of the problem. But I think in terms of raising public awareness, of generating excitement around it, and frankly, housing some extremely vulnerable people, it's a very good thing, and we're proud participants in it.
If I could even tag on
Please.
to Kevin's piece too. One of the things this is a tremendous initiative, so all kudos. At the same time, we haven't changed really any underlying causes of new vulnerable people coming onto the street. Mm-hmm. And so it's in some ways, and I speak with my national hat on, this is like bailing out the bathtub but not turning off the faucet. And so I would like to see these initiatives coupled with larger access to affordable housing for people who have not yet been considered and scored so vulnerable that they're considered the 75 sickest people in Baltimore City living on the street. That's a dubious badge to carry. And so I would like to see this coupled with larger policy change to address the structural factors that Kevin outlined earlier.
And what it does to take 75 housing vouchers or 75 housing placements and direct them toward extremely vulnerable people is to take those 75 opportunities away from other people. So to Barbara's point about the bathtub and the faucet still running, the downside of this initiative is we seem to be enshrining in law the so-called chronically homeless. And there's a federal definition for what it means to be chronically homeless. The only difference, though, fundamentally, the main difference between someone who's living under the bridge and has been there for a really long time with serious mental health and addiction problems, and the woman who's a few months behind on her rent facing eviction, the main difference between them is time. So point being, if we don't do more to prevent homelessness on the front end, we're simply producing next year's chronically homeless population.
Okay, we have another question online. I very much appreciated your presentation, particularly your perspective on the Affordable Care Act being a Jobs Act. How do you handle the argument that it does not necessarily create more jobs so much as it creates more work for an already shrinking field of primary care physicians?
There are a number of provisions in the Affordable Care Act that specifically increase the number of primary care providers, not just physicians, but nurses, physician's assistants, dentists, and other I think select mental health therapists, trying to go through the whole list. The National Health Service Corps is one provision. If anyone is interested in getting paid to go to medical school or getting help with those loans, National Health Service Corps. And there are a number of other provisions too that provide incentives for taking some of the burdens that primary care providers already carry and shifting that to an other type of workforce. We need our physicians and our clinicians and all of our clinicians to be working at the top of their license. And there's no reason why we need to have licensed healthcare professionals doing a lot of paperwork. So this is some of the principles behind patient-centered medical home and some of the other things where we are shifting how we do healthcare in general. So I am absolutely sympathetic to the point where all clinicians are feeling overwhelmed right now. And they're feeling like there's this tidal wave of patients that are going to be demanding care in the future. And we know that there's pent-up demand. So clearly this is a balance we need to have. But there are a number of provisions in the law that I just didn't have time to go over today that will increase the workforce, providing incentives for lower-end primary community care rather than the specialty care that we really heavily rely on in the country. And so again, I would urge people to look broadly to this because again, it is a jobs bill for bringing additional people in to help with that demand.
The questioner is very right, though, to be concerned that initially there will be insufficient capacity. So hopefully policies will shift and there will be greater capacity long term. In the short term, I think we've got a real access problem when health reform goes into effect in 2014.
I think we've seen also in some other, particularly in Massachusetts, where you did initially, like Kevin said, see a spike, but then over, I think it was only a few years where you saw that come back down into equilibrium. And so I think we shouldn't be too quick to call anything a failure when we are trying to change some very intractable systems in a very short amount of time.
Good point.
Any questions from the audience? I'll continue with the online questions then. What is Baltimore doing specifically to increase non-transition housing for this population?
What are we doing to increase non-transition housing for the population? What we've been doing is primarily providing the comprehensive supportive services that keep people stably housed and off the streets. We started with a small pilot project in collaboration with the city back in 2005, where we took 30 people out of a downtown park, moved them into housing units that were paid for with housing vouchers provided by the city and through another federal funding source. That was expanded through a Substance Abuse and Mental Health Services Administration project to additional people. It's been expanded in some other ways. We're working to expand it now. But Healthcare for the Homeless itself does not develop or own the housing. It's all private housing and paid for through vouchers. I think we're very interested recognizing that funding for affordable housing is decreasing and shows signs that it will continue to decrease. We're interested in looking for new ways and partnerships to actually make new units available. We're not currently involved in that right now. Our long-term strategic plan over the next 5 years envisions furthering partnerships to actually produce the availability of housing that's affordable to extremely vulnerable people.
Okay, here's another question from online. I know that you spoke about the limitations of electronic medical records, but do you think that eventually that they'll help with continuity of care issues for the homeless population?
Yes, I do, but I'll qualify that by saying homeless populations, and I don't want to speak, and as if this population is singular. It's a very diverse group with very diverse needs, but on a whole, they're going to be seeking care in a lot of different places. By definition, people will be moving around where opportunities are available to them for housing or meeting other basic needs. So it's not unusual that they will receive care from 6 different hospitals, see a number of different community health centers or other providers. So yes, but it means that we have to have access to those records across venues and possibly across cities. And if I can just do a hallmark. The best medical record system in the world that I'm aware of is the VA. You can go anywhere in this country, you can go anywhere in the world on any U.S. Army base or military base, and you can have full medical records of any individual. And I just find that's the gold standard. But right now, and I'll just be honest, is we have a million different IT analysts and startup companies and tech boom that is developing EMR systems across the country, and everyone's out there with their business card trying to sell you their system. Very few of these systems are designed to easily integrate with everyone else. So then, isn't this brilliant? So then we get to hire more contractors to build bridge systems so that we can then we can connect provider A to provider D, but then we'll have someone else do it for B and C, and then we just get into this spider web of workarounds when in the end it doesn't actually unify our healthcare system. It ends up being much like the one we have now, right? A fragmented collection of programs. And so again, a single payer version of medical records would be where we need to go in order to maximize the real vision and potential behind the use of data. But certainly where we're going is a good step in the right direction. But I just wonder if we're not have 1,000 different threads of the same idea.
Is there some hope that the technology goes in that direction? I think yes, but perhaps more in the long term. There are interesting efforts in some communities in Maryland, CRISP, the Chesapeake Regional Information Exchange, looking at unifying these various systems so that providers like Healthcare for the Homeless and others can actually get real-time hospital information on when people are being admitted and when people are being discharged. There's other relationships between health centers and hospitals where they're trying to share information in a better way through their electronic systems. But the true integration, I think that the questioner envisions and that Barbara's talking about is years and years off.
Okay. Another question from online. What pilot interventions maximize the chance that those who are eligible for Medicaid but don't have it will enroll and stay enrolled?
There are a number of provisions that we know from current Medicaid experiences with predominantly kids and parents. Fast lane eligibility, presumptive eligibility. The law does give hospitals the ability to do presumptive eligibility for this population. And so if people are going to be coming into a hospital system, they'll be able to get very quickly enrolled. Obviously, the hospital is interested in getting paid, but we're also interested in connecting people to care as far as discharge goes. So we do know that there are some things we can do, and again, fast track eligibility for clearly eligible people that are considered best practices, and a number of states have adopted. And so we're hoping the improvements that I described with enrollment are actually based on what we've learned from those pilot studies over time. So I'm excited to see those go broad scale.
Can you talk a little bit about you mentioned that coming up in the legislative session, there's a bill that addresses continuity of care. Are there any other proposed legislation that will address aspects of the healthcare issues for the homeless population?
We recently just had a conversation where we're trying to understand what's ahead of us. We do anticipate that there will be a bill that's introduced that fixes some of the continuity of care aspects that we talked about earlier again, and providers needs to accept another provider's approval for treatment, making sure that continuity is there. There's fixes that we need to put into our insurance law that give insurers the ability to make those accept other people's authorizations. So we're anticipating those pieces. I imagine those are going to be very technical bills. We're fixing very minute pieces of insurance law, and this probably will not be. This is the drier aspect of policy in terms of insurance law, but very fundamental for ensuring continuity of care. I haven't seen the bill language yet, so I don't know the extent of it. And Kevin probably has some more detail.
I would just imagine that most of the health-related legislation this session will be around preparing for and fixing things for 2014. There will be some other legislation giving lawmakers the opportunity to address poverty. There will be a minimum wage bill, for example, giving Maryland the opportunity to join the 19 other states that already mandate higher minimum wages than the federal floor of $7.25 an hour. That would be a very good thing, even from a healthcare perspective. There will be a affordable rental housing bill that doesn't target down the income scale as low as we would like, but nonetheless it will mean that people in the lower and middle class that are struggling to make ends meet will have improved access to affordable housing, and that in the long run can prevent homelessness. So we think those measures are good and important.
And if I can even just add, there's two other bills that are important for us, not directly related to healthcare, but still very important for this population. The HOME Act, which is a bill that would prevent landlords from discriminating against your legal source of income. Right now, if I'm a landlord, I can't discriminate based on gender, religion, race, sexual orientation, or a number of other factors, but I can deny you housing based on the fact that you have a Section 8 rental voucher, the fact that you have a pension, or get your income from child support or alimony. We see that as a real barrier to obtaining housing. Kevin talked about those vouchers being very, very scarce. You have 60 to 90 days to use that voucher once you get it. You might have waited 7 years on a waiting list for it. And once you get it, no landlord will take it. And this is part of the problem in creating barriers to care. When we disinvested in public housing and we turned it over to the private sector, this is what we created. And so, again, these are the kinds of things we'd like to fix in the law. There's a piece too, ban the box. Our folks could exit homelessness if they could get a job, a decent paying job, one that had more than a minimum wage. But if you have a box on an application that says, have you ever been convicted of a crime, and you check yes, no one is going to interview you, even though you may have a master's degree and that crime might have been 20, 25 years ago. So we're advocating that we move that conversation further into the interview process so that people at least have a chance to interview and present themselves and explain their situation as a way of just getting a better fighting chance at a job. And I think that that's what we're all interested in. So again, it takes us a little bit away from healthcare, but at the same time, these are the kinds of things that stabilize our clients. And if we can get people stable in a job and housing, that has direct implications on their health.
So I can speak a little bit more to that. My name is Jen Kirshner. I'm from Baltimore Student Harm Reduction Coalition. I'm also a member of the SHARP Coalition, which is Stopping Homelessness and Reducing Poverty, to which Healthcare for the Homeless is a part. I just want to say, for anyone who is interested in advocacy, there's a joint coalitions meeting this Friday, the 18th, at 4:30 p.m. at Stadium Place, and that's going to be about some of the bills we just talked about. The HOME Act, which is about source of income discrimination, the Ban the Box. There's also criminal record shielding, which would shield certain convictions from the public while still keeping records fully available to law enforcement. Some others, like sick and safe leave. So there is a lot going on in this session. It's coming up very quickly. So the Ban the Box hearing is actually tomorrow in Annapolis. And February 28th is Homelessness and Reentry Lobby Day. That's going through Healthcare for the Homeless. They'll be providing buses down to Annapolis. So I'm sure on their Twitters that were put up there, that information can be found.
One of the Ban the Box hearings is actually taking place right now as we speak. And the other one, as you noted, will be tomorrow. Yeah.
Here's an online question that
Momentary technical problems.
Excuse me. Here's another online question that is coming from a little bit of a different perspective. There are some people who are living long-term under an 83 overpass. Are there any people such as these who don't want assistance? And if yes, what are their rights?
we're seeing who's gonna take this one. I've been doing this work for about 20 years. Barbara's been doing this work for a very long time. Colleagues of ours around the country doing this for decades. I can honestly say that I've not met anyone as a direct clinician or now as an administrator who wants to be homeless. And I often hear questions about choice, and I think it's far more complicated than that. And there may be some underlying things happening, but when push comes to shove, if someone is offered a place to stay on their own terms and the resources and the supports that they need to stay there, we find that we can engage almost anyone who might initially tell us that they don't want our help and that they want to stay exactly where they are. We can engage those folks into housing and off the streets. People don't want to be homeless. And we need to kind of overcome that myth out there that's existed for quite some time that there's a percentage of people who do.
And if I can add to that too, I think this is a really important point for people to understand because I think it's confusing. And I think it does lead to an inability to have an honest conversation about homelessness because what we see and hear, well, they must want to be homeless because when we offered them to go to a shelter or to this program or that program, they didn't want to go. And so, well, we wash our hands of it and say, well, there's just no helping some people. They must want this life. And I guess when we think about thinking through the details, what do we offer them when we go out? And we say, hey, I got a program for you. You know what that means generally? And I mean, this is broad, but it means I'm going to put you in a place where you have to check in and out, where people will monitor your every move, where you have to be in by 8 o'clock, maybe even earlier, maybe by 6. You have to stand in line in order to get there. You have to be out by 6 a.m. You can't drink. You can't have friends visit. You can't have your girlfriend or your boyfriend visit. You can't have your wife or your husband visit. You can't have your children visit. You will have to share a room with maybe 2, but maybe 50 people, all of whom are having the same kind of crisis you're having. You will likely have most of your stuff taken from you, like stolen. And that includes prescription drugs that you need in order to maintain your health. We're replacing prescription drugs for people all the time. Or you could live under the overpass where you can sleep as long as you want. You can have a drink after a hard day. You can, there's a freedom there that we're not actually offering people. When we offer people help, what we're really doing is we're offering them what we want them to do and follow our rules. And I'll tell you, I think everyone listening to this webcast right now and here in the room, I know I go home at the end of the day and I have the freedom to have a drink. And I have the freedom to have whomever I want in my house. And I have the freedom to have my housing on my terms. And none of us would think of having someone come in and put those kinds of rules on us. It's inconceivable. But yet we're going to ask that of others. And then we wonder why they don't want it. I like sleeping in on a Saturday and a Sunday too, by the way. And so, again, it's the kind of thing where why would then we hold them to a different standard than we would want ourselves? So this is the idea behind Housing First. I've never met anybody who, when you went with a house key and said, I got a place for you, it's yours. You can do with it what you want. You can decorate it the way you want. You don't even have to decorate it. And you can have whatever you want in your refrigerator, and you can eat when you want, and you can eat what you want. And if you want to have friends over, that's okay too. It's your place, like regular people. You want to know what? If we could do that with everybody under the 83, there wouldn't be anybody under 83. But when we go out and we offer people under 83 the kind of homeless services that we have, it's actually a pretty logical choice to say, no thanks, I'm not interested. I know that's what I would do. And so I emphasize it because I think it's really important to understand what we're really offering people when we offer help.
We're going to have to end on that note. And actually, I really appreciate that we got a chance to look at those kinds of issues also. And I really want to thank both Kevin and Barbara for doing a fantastic job in terms of, number one, their work and advocacy, and number two, really presenting the public health community with important information and important things to think about, maybe a little bit differently than we've thought about before, and ways that we can expand our services and ideas about how to help this vulnerable population. So thank you very much, and I hope everybody online will tune in on February 20th. We do our rounds the third Wednesday of every month, and our topic will be gun violence prevention and the National Violent Events Reporting System. We will have the PowerPoints for this presentation posted no later than this Friday, and we will have the actual archive of the webcast up within 2 to 3 weeks. So that will be available, and we will send out a notice when the archive is available. So thank you very much.